I thank the Uttarakhand Ophthalmological Society for this honor, and I thank Saurabh for this elaborate introduction. I'll be speaking about a topic which is very close to my heart, retinoblastoma. What are we doing today to enhance survival, obviously improve eye salvage and vision salvage as part of the CS Grower oration? Why should we know about retinoblastoma at all? Because it's the most common intraocular malignancy in children. It's a deadly tumor with more than 50% mortality if not managed appropriately. And it presents to an ophthalmologist first because these children do have symptoms related to the eye such as leukocoria and strabismus, because of which they come to the ophthalmologist. And it is completely curable if it is diagnosed early. Nearly 98% survival is possible if retinoblastoma is diagnosed early and treated appropriately. You see from this retinoblastoma map that India is still a hot zone. A lot of retinoblastoma occurs in India mainly because we have a higher live birth rate. The incidence that is estimated in India is about 1,500 to 2,000 new cases per year, which may not seem like a big number, but it is actually the highest number for a country in the world. But the striking data is that out of these, only about 600 to 800 are referred to retinoblastoma treatment centers, which means that more than half these patients are treated at primary or secondary levels where only enucleation is possible, nothing beyond that, which has a higher mortality of about 30 to 40%. So just by augmenting care in terms of referral, channelizing these patients and triaging them for appropriate management can save a lot of lives. This one slide sums up the evolution that has taken place in the realm of retinoblastoma. From 98% mortality just about 124 years ago, we have more than 98% survival. This is miraculous because it hasn't happened in any other malignancy except retinoblastoma. No other cancer has this kind of a turnaround in terms of survival. Clinical manifestations are absolutely straightforward. These children are actually staring at you begging for a diagnosis because they have this striking leukocoria. Leukocoria happens in 50% of children. This is the most common symptom as well as the sign, unilateral or bilateral. Squint comes next, 25% of children. Externally evident, you don't need any investigations to diagnose that this child has retinoblastoma because lurking behind that esotropic eye is this subtle white reflex. So every child with squint has to undergo at least a distant direct ophthalmoscopy by the first ophthalmologist or an optometrist that sees the child, and beyond that, of course, a dilated fundus evaluation is mandatory. Macular tumors result in reduced vision or poor visual attention, especially if the tumor is bilateral. This is a situation where the tumor is already advanced. This is secondary glaucoma, cataract, neovascular glaucoma that presents in an advanced tumor. Fortunately, this has become rare. This is an orbital manifestation of retinoblastoma, and the fungatic tumors are almost non-existent currently in India, very rare in some states. We should also look at the masquerades of retinoblastoma. If you have a child with preseptal cellulitis or orbital cellulitis, there could be a lurking retinoblastoma behind because necrotic retinoblastoma produces sterile orbital inflammation that may look like orbital cellulitis. You should always do a B-scan ultrasound in every child with preseptal or orbital cellulitis. This is hypopyon. You may think that it is uveitis. It is not, because there is no circumciliary congestion at all. Right? Any white eye hypopyon should be viewed with a lot of suspicion because white eye hypopyon is a sign of retinoblastoma and also medulloepithelium of the ciliary body. This may look like developmental glaucoma to you, but behind which you see a yellowish white reflex. This is bilateral retinoblastoma with bilateral glaucoma, and any child with glaucoma obviously can have an enlarged cornea and a larger eye. This looks like phthisis bulbi, it is, but it is secondary to a necrotic retinoblastoma. Parents come to you with a history of trauma or subtle trauma in these situations, or just a history of redness, and you may miss the lurking retinoblastoma. Whenever you do a CT scan in these patients, if the calcification is within the eye, intraocular calcification, that suggests retinoblastoma, whereas if it is in the coats of the eye, choroid and sclera, that is dystrophic calcification in a phthysical eye. You have to image every child with a phthysical eye, otherwise you're going to miss this retinoblastoma. This child presented with hyphema, full chamber hyphema, with a history of trauma, even with a small lid laceration. Obviously, the child has had trauma and has developed hyphema, but the treating surgeon thought that it was traumatic hyphema. He drained the hyphema, child has high IOP. He did a trabeculectomy as well. And 6 months later, the child comes with an extraocular extension of retinoblastoma, regional lymph node metastasis, and intracranial extension as well. A situation from which we can't save this child. Vitreous hemorrhage is also a manifestation of diffuse infiltrative retinoblastoma. So these are the masquerades of retinoblastoma. The diagnosis is absolutely straightforward. I showed you leukocoria and strabismus. Those are external signs. When you look at the tumor, diagnosis is very clear. It's with indirect ophthalmoscopy that you would diagnose retinoblastoma. Ultrasound helps measure the height of the tumor and also detect intralesional calcification. MRI is mandatory for advanced retinoblastoma to know if there is choroidal invasion, optic nerve extension or extraocular extension, and also to screen for pinealoblastoma. There are recent advances in imaging, which is wide field imaging, etc., but then those are reserved for treatment centers. There are 4 clinical types of retinoblastoma. Endophytic, where the tumor grows into the vitreous, is the most common. Exophytic tumor produces exudative retinal detachment and subretinal seeds. Endophytic tumor produces vitreous seeds. This is diffuse infiltrative retinoblastoma, where the tumor is very flat, not a nodular or an elevated tumor, and the mixed configuration. This is what you see when you do indirect ophthalmoscopy. Most common simulating conditions are Coates disease, PHPV, toxocariasis, astrocytic hamartoma, and medulloepithelioma. In Coates, you find a altered reflex, but that is xanthochoria. Xantho is yellow. Golden yellow reflex is what you see in Coates disease, whereas in retinoblastoma, you see this striking yellow-white reflex. So just by looking at the quality of the reflex on distant direct ophthalmoscopy or with a good illumination, you will be able to clinically ascertain whether it is Coates disease or retinoblastoma. And when you do indirect ophthalmoscopy, you see this in Coates disease, where you find a lot of exudates, intraretinal, subretinal exudates, and peripheral retinal telangiectasia. That is characteristic of Coates disease, whereas in retinoblastoma, you don't find that. In PHPV, the eye is relatively microphthalmic. Even a millimeter difference in the diameter of the cornea may be suggestive of PHPV in a child who has prominent ciliary processes and also a posterior polar cataract with a fibrovascular front arising from it and connecting it to the optic disc. These children do present with cataract, and that is how you differentiate it. Now, toxocariasis can be of 2 types, peripheral as well as macular. In peripheral toxocariasis, you find this fibrovascular traction band, which is very suggestive, whereas in retinoblastoma, you don't find it. In macular toxocariasis, you find the drag disc appearance, where this desmoplastic activity around the lesion drags the blood vessels towards it, and there is also a thick epiretinal membrane, whereas in retinoblastoma, you don't find that. In retinal astrocytic hamartoma, non-calcified variant sits like a button on the retina, obscuring the blood vessels, whereas in retinoblastoma, you see blood vessels over it, passing through it, and sometimes even exiting from it. The calcified variant looks like this. This is like fish egg calcification. Medulloepithelioma is a ciliary body tumor. It is not a retinal tumor, and these children present with zonular coloboma or lens coloboma. The zonules are missing in the area where there is medulloepithelioma because it's an embryonal tumor, resulting in what looks like a lenticular coloboma. It's not actually a lenticular coloboma, it's a zonular coloboma distorting the lens, whereas in retinoblastoma you don't find it. Coming to classification, all classification should follow a logical sequence. They should be able to prognosticate the disease. That is why you classify at all. Otherwise, what is the need for classification unless you use it to tell parents, okay, this is a chance of eye salvage, this is possibly the chance of life salvage. There are 2 ways of classifying. One is staging, where the survival is the outcome. Second is grouping, where eye salvage is the outcome. For staging, we have International Retinoblastoma Staging System, where stage 0 is the eye which has been conservatively managed, no enucleation is performed. Stage 1 is tumor completely resected. This is the operative word here. How do you tell that the tumor is completely resected unless you have done a good pathology evaluation by a protocol-based manner? Unless there is microscopic residual, you can certainly say that the child belongs to stage 1. So stage 2 is microscopic residual tumor, which means sclera, extrascleral extension is there, sclera has full thickness involved, vertex veins are involved, or the optic nerve is involved up to the level of transection. Stage 3 is regional extension to orbit and lymph nodes, and stage 4 is metastatic disease. Up to this stage, there is 95% survival. Beyond that, survival reduces to less than 5%. So that's the watershed zone between stage 3 and stage 4. You have to identify patients before they reach stage 4 for sure. International grouping of retinoblastoma is very simple. It's a kindergarten classification. A is for small tumors, B is for bigger tumors with macular location or subretinal fluid, C is for contained or confined subretinal seeds in exophytic retinoblastoma and vitreous seeds in endophytic retinoblastoma. Remember, D for diffuse subretinal or diffuse vitreous seeds, and E are potentially enucleable with tumor filling more than 50% of the vitreous volume, neovascular glaucoma, and anterior segment or choroidal infiltration. AJCC classifies any tumor as TNM, tumor node metastasis. For the first time, a new alphabet has been added to TNM, that is H. H is for heritability, bringing in genetics to the forefront in the management of retinoblastoma. Coming to management, the goals are to save life, and if that is possible, to save the organ, and if that is possible, to optimize visual function. In a small tumor which is hardly about 3 to 4 millimeter in diameter or 3 to 4 millimeter in thickness, life salvage is not at all in concern. Eye salvage is taken for granted. So what you need to do now is to maximize vision, and that is possible with focal therapeutic modalities. Cryotherapy is good, but it always results in a much larger scar than you began with, because cryo is very heavy here. Triple freeze thaw cryotherapy, where the tumor is indented on top of a 3 millimeter cryoprobe and it is frozen stiff until the vitreous that's anterior to it also condenses. In that situation, it is reasonable to expect a large scar and also atrophic retinal holes, which may lead to hematogenous retinal detachment. So cryo is generally not performed now unless that is the only option that is possible, specifically reserved for nasal peripheral tumors, not for temporal ones. Photocoagulation is also something that is not recommended because the blood vessels that pass through the area of laser get occluded, and the scar is much larger than the tumor that you began with, because you surround the tumor with 2 rows of large diameter laser burns, resulting in a much larger scar. The current practice is to use transpupillary thermotherapy, which is gentle. It is done on top of the tumor using 1000 to 300 micron laser spot, which takes very little time because it is as large as the optic disc, the laser spot. So in about 3 or 4 spots, you can cover the entire tumor, and the blood vessels that pass through the tumor are classically patent with TTT, as you see in this magnified image. And the new advance in TTT is the photodynamic effect of ICG when it is used along with TTT. That can take care of tumors that have recurred on top of a pre-existing non-pigmented scar. Brachytherapy is not new, but the way it is done is relatively new. In brachytherapy, use a ruthenium plaque which sits around the optic nerve in a macular tumor so that the disc remains healthy yet the tumor regresses. Otherwise, there is no way we can treat this particular patient with brachytherapy when the tumor is right next to the optic nerve. One more example where brachytherapy has been used. So plaque brachytherapy has very specific indications in retinoblastoma. What really brought about the paradigm change was the onset of chemotherapy. This came in 1996, long ago. But then we started with intravenous chemotherapy. Now we have all these various forms of chemotherapy to give. Intravenous chemotherapy or chemoreduction reduces the size of the tumor using these 3 drugs, carboplatin, etoposide, and vincristine, given 3 weekly. How does it work? Number 1, it reduces the size of the tumor to much smaller scar. That is how macular fovea get exposed very early in the course of treatment, thus maximizing vision. Second is that the tumor always hangs on to its source of blood supply. All posterior polar tumors get blood supply from one of the major arcades, and here it is a supratemporal arcade that is giving blood supply to the tumor. Initially, the tumor is abutting on the fovea macula. As we start our chemotherapy, tumor moves away from there and regresses towards its source of blood supply to which it hangs on. After 3 cycles, macula is absolutely healthy, fovea is healthy for good vision, whereas the tumor has moved away from it. The third principle of chemotherapy is that the subretinal fluid that the patient has regresses very early in the course of treatment, thus maximizing vision. You can see here that the SRF has reduced and the tumor has moved away from the optic disc, which is not even seen in the first visit, thus maximizing vision. So it shrinks the tumor regresses towards its source of vascularity, thus freeing macular fovea, and exudative retinal detachment settle down, all these three put together, the patient gets much better vision. Intravenous chemotherapy was the standard of care. It is still the standard of care in India because of cost considerations. IAC otherwise is the standard of care in the rest of the world. We do have technology for IAC very extensively available in India, but cost is a barrier. Here we get access to the ophthalmic artery, and when we take over and inject three drugs, melphalan is the drug of choice. Along with that, we inject topotecan and carboplatin to enhance the effect of intraarterial chemotherapy, and the results are quite dramatic. This child with total exudative retinal detachment settled very soon with a regressed tumor. Another child with total RD settled into a calcified scar. Results are very dramatic and well sustained, even in situations where the tumors are extensive and large and even recurrent tumors as well. It does make a difference in group D and E retinoblastoma. In D, it provides an additional eye salvage of about 10 to 15%, whereas in group E, it provides an additional eye salvage of about 10% over intravenous chemotherapy. It is definitely beneficial if the child has access to it. Next part is about the vitreous seeds. Vitreous seeds were the major bugbear in the management of retinoblastoma. We only knew about the classic vitreous seeds earlier. Now we have a new subclassification. These are classified as prehyaloid, subhyaloid, epiretinal, preretinal, and even intracameral. These are classic vitreous seeds. These are prehyaloid vitreous seeds. These are subhyaloid seeds. These are epiretinal, intraretinal, and subretinal seeds, all in a same patient. These are depository anterior chamber seeds which walk through the zonule and come into the anterior chamber, whereas these are infiltrative anterior chamber seeds where the iris and the trabecular meshwork are already involved and there are anterior chamber seeds. Morphological classification would depend on how the seeds look like. This is dust, cloud, sphere, and mixed configuration. Now, how do we treat these vitreous seeds? After the retinal tumor has completely regressed, we bring in intravitreal chemotherapy, which is a safety-enhanced intravitreal chemotherapy from a safe zone diametrically opposite to the location of the retinal tumor and also the active vitreous seeds. You go as far away from the active vitreous seeds as possible. Then we inject the drug. Melphalan was the drug of choice. It is still a drug of choice in the West, but we have stopped using it because of certain considerations. This is the first patient that was treated with melphalan, did very well. But as we started using more and more melphalan, we started finding a new complication that was earlier not described, retinal pigment epithelial atrophy, which happens specifically in pigmented eyes such as ours. So we started using topotecan, which is a much better, more forgiving drug, much effective. And our long-term review that was recently published shows that these children have much better outcome as compared to melphalan. 30 microgram is used 3 weekly, and you can see nice regression after 2 to 6 injections of intravitreal topotecan. It is non-toxic to the retina, does not induce uveitis. All these patients have been treated with intravitreal topotecan with good results. When the patients have a refractory seeding, then we combine topotecan with low-dose melphalan, again with good results. This is how the patient presented. Bunch of vitreous seeds. After chemotherapy, retinal tumor regressed, vitreous seeds remained. After topotecan, vitreous seeds are much less. When we combined it with melphalan, they're gone, but note that there is RP atrophy in certain areas of the fundus. So we can use a dual therapy as well. This is a regression pattern of vitreous seeds. Anterior chamber seeds were earlier an indication for enucleation, now no longer so. We inject intracameral chemotherapy, topotecan 5 microgram is what is used. If they have vitreous seeds also along at the time of presentation, we can give intravitreal chemotherapy as well. This is very safe to the corneal endothelium, does not cause endothelial problems at all. This is a patient where there is ciliary body involvement and anterior chamber seeds. This is the only eye of this patient. Other eye had already been enucleated. For the ciliary body component, plaque brachytherapy came in. For the anterior chamber seeds, intracameral chemotherapy came in. Both regressed, as you can see here, with good visual preservation. We also found that the patients who have intraretinal and subretinal seeds, where earlier we were doing extensive laser resulting in retinal scar, can now be treated with a simple injection. We don't do laser now anymore because that actually precludes good visual acuity, and give them injections, and that is supposed to take care of the seeds as well. In group E retinoblastoma, obviously there is a need for enucleation in the bad group E eyes with neovascular glaucoma, etc., where we aim for a long optic nerve stump. 10 millimeter as given in the books is suboptimal. We aim for an additional 5, 6, 7, 8 millimeter, 18 to 19 millimeter is a stump that we achieve. Primary implant in every patient with good cosmesis because of a custom prosthesis. Long optic nerve is mandatory. Following enucleation, about 20 to 30% children are reported to develop metastasis. That mainly because the histopathological risk factors were never identified. Pathologists would give the diagnosis of retinoblastoma with which the ophthalmologists were happy, and then nothing was done because the tumor has been enucleated. They thought that that is the end of treatment. When we started noticing that 50% of Indian eyes have these risk factors, iris ciliary body involvement, choroidal involvement or optic nerve involvement beyond lamina cribrosa or to transection, we started looking at the rate of metastasis. All these risk factors were studied by the pathologist, and then we found that these children have about 30 to 40% chance of developing metastasis. In these patients, we give adjuvant chemotherapy following enucleation. And every patient who has optic nerve involvement up to transection or extraocular invasion, we have to give adjuvant orbital EBRT as well. Does it really help? The literature was divided, but this large study that we did actually settled the issue. In a patient where adjuvant chemotherapy was not given, the risk of metastasis was 24%. Just by giving adjuvant therapy, the risk of metastasis could be reduced to 4%. Direct survival benefit to 20% of children, which is a big number. 1/5 of children you're able to save just by this simple measure alone. Pathology costs almost nothing, and chemotherapy is very inexpensive, so to say, less than the cost of even a single piece lens, PMMA lens. That is the cost of chemotherapy. With just that measure, possibly you can save a lot of lives. This was later corroborated by the Children's Oncology Group multicentric study. So enucleation is not the end of management of retinoblastoma. Last bit is about orbital retinoblastoma, where the incidence actually varies, but it has high rate of mortality. 70% was the mortality with orbital exenteration that we used to do earlier. It can be classified as primary, where the child with orbital RB presents with orbital RB. This is clinical manifestation of orbital retinoblastoma. This is on MRI that we noted that there is an extraocular extension. Secondary is orbital recurrence following enucleation. All these children had 70% mortality. Now we don't do orbital exenteration anymore in these patients. We do multimodal treatment. We begin with neoadjuvant chemotherapy for the orbital component. That regresses, and the eye goes into a comfortable phthisis. When we enucleate with a long optic nerve stump, follow it up with stereotactic radiation and adjuvant chemotherapy. It works even for optic nerve extension. This child had optic nerve extension right up to the orbital apex, completely reduced following neoadjuvant chemotherapy, now safe for enucleation. It works for intracranial extension. This child had extension to the cavernous sinus, which is extremely difficult to manage. These patients were earlier just given palliation. Now with neoadjuvant chemotherapy, that is reduced. The part around the superior orbital fissure can be easily treated with stereotactic radiation. Of course, the child needed enucleation. What is another thing that is good about these children is that we are able to give them good cosmesis. Since we don't have to do orbital exenteration, we can actually give them custom ocular prosthesis. Even in this situation where the lid was infiltrated, it became completely flat after treatment, and these children could get a customized prosthesis. So orbital RB also now has a cure. With all this put together, the prognosis in India almost mirrors what we see in the West, 95% survival, whereas in the West they have 98% survival, all with cost-effective treatment modalities. Chemo reduction can save about 90% of the eyes, 95% have vision salvage, and where vision can be recorded in older children, 50% have vision equal to or more than 20/40. These children actually do very well in life. In conclusion, I would say that Group A are treated with focal therapy. Group B, if it's in a visually critical location, then obviously chemotherapy of any form is the ideal initial management because we want to optimize vision. Group C, D, and good E are treated with chemotherapy, ideally intraarterial chemotherapy, but if that's not possible, at least intravenous chemotherapy followed by focal therapy. Bad E are subjected to enucleation, but definitely with histopathology guided adjuvant therapy. Stage 2 is adjuvant EBRT and chemotherapy, and stage 3 is multimodal therapy. Stage 4, of course, palliation for now. So in conclusion, I would say that cost-effective protocol-based management by a multidisciplinary team in an ophthalmic setting for retinoblastoma can actually help outcome in terms of life salvage, eye salvage, and vision salvage as well. Thank you so much.